you, class? My name is Wilson, and today I'm going to be presenting my case. I was at a clinic, and even though I saw many unique cases with a lot of really, really interesting things, this was the one that I chose for my presentation. Now, before I get into it, I'm just going to give some brief patient information. The patient was a 69-year-old male who complained of lower back pain occurring for about a week. Patient clarified that no trauma had occurred, so this pain just came out of nowhere. The patient also made it clear that it was difficult for him to bend down and sit straight for an extensive period of time. We also verified that the patient has a history of diabetes and was of a stenic body habitus. And at the time, the patient was taking no medication for the pain of the lower back. And before I get into the projections, I just want to give you guys a brief anatomy of the lumbar spine. In the lumbar spine, there are five bones in total. We also have the sacrum and the coccyx. Now, the lumbar spine, each lumbar vertebrae is large, and they are large and they are strong because it is a common site of injury. Because this part of the spine receives most of the body weight. Each vertebral body is composed of two pedicles, two laminae. There are also seven bony processes on each vertebra, which include the one spinous process, four articular processes, and two transverse processes. Now, we also have certain things that we look for on a radiograph. For example, the vertebral foramen of the lumbar spine, which is formed by the superior inferior vertebral notch, which is seen at a lateral projection or 90 degrees. We also have the zygapophyseal joints, or the Z joint for short, which are formed by the superior inferior articular processes and are seen at a 45 degree oblique projection, also creating the Scotty dog, which is only seen on a oblique projection of the lumbar spine. Uh, Moving on to the projections that I did, the doctor referred only three views, which were the AP projection, lateral projection, and the lateral 5S1 projection. And now for the AP projection, what I did was, just as any other lumbar spine, the central ray was directed at the iliac crest, which is at the level of L4, L5. The patient was on the table, so the patient was in a supine position with the knees flexed, arms to the side, four-sided columnation. The IR was lengthwise, 14 by 17 inches, and using an SID of 40 inches. Now, for the lateral projection, the patient was still on the table. However, we told him to, to roll on his left side, and he was now in a lateral recumbent position. However, the central ray was still directed at the iliac crest. The knees were still flexed. I also tried to still get a four-sided combination. The IR was still lengthwise and the same size, 14 by 17 inches, and the SID was still of 40 inches. Now, for the lateral L5S1 projection, most of the things, some things changed. The central ray was directed now to 1.5 inches inferior and 2 inches posterior to the ACES. The patient was still in a lateral recumbent position with the knees flexed, and the IR was still lengthwise. However, the size decreased, going from 14 to 17 to now of 8 to 10 inches, and the SID was still the same of 40 inches. Now, when we received the radiologist report, it was stated that the normal lordotic curve of the lumbar spine was preserved, so nothing was wrong there. There was no loss of vertebral body height. That the pedicles of each vertebra remained intact. However, there were some abnormalities that were found, and they were that the patient had grade 1 anterior listhesis between L4 and L5, that vertebral body osteophytes were at all levels, and that the patient had mild dextroscoliosis. Now to go into depth with anterior listhesis. Now, anterior listhesis is the anterior slipping of the body of the vertebra. This is also known as spondylolisthesis. And just the fact that I found interesting was that This slippage most commonly occurs at the L5S1 junction, and it commonly affects individuals over the age of 50. Now, the causes. I have a few here. Some of the causes can be congenital, having a defective joint since birth, an accident or trauma, which causes damage to the joint. It can also develop over time through strenuous physical movement, that being at work or if the person is a bodybuilder, which leads to the overuse of the joint, and because of aging, which in turn the cartilage between the vertebrae weakens and thins um, due to aging. And some of the symptoms, which depends on the amount of slippage, uh, can be consistent localized pain, pulsating or tingling sensation, decreased flexibility, and muscle spasms. And the degree of slippage is classified on this system called the meridian classification system. Now, the degree of slippage is graded from 1 to 4, with 1 being the least severe and 4 being the most severe. And I'm going to break down each one. Grade 1 would be 0% to 25% slippage, and the patient would only be referred pain medication and rest. Grade 2 is a bit more severe. The slippage is now 26% to 50% slippage, and however, the patient will still receive just pain medication and some rest. Now, when we go to grade 3, the slippage is now 51% to 75% slippage, and it would require the patient to receive therapy and probably use a brace or some back support. And then we have grade 4, which is 76% to 99% slippage, and this is a severe anterior listhesis, which would have to require surgery. And as you guys can see here in these pictures, if you guys look at the arrows, there is slight anterior slippage, which is why the radiologist graded it as grade 1, because it isn't really prominent. And another fact that I found interesting was that even though it's not part of the meridian system, grade 5 refers to 100% slippage, meaning that the vertebra slips completely off of the vertebra underneath it, and the only way to fix this would be through surgery. And there are two types of surgery that can help fix this. One would be where the bone or other tissue is removed to release pressure on the vertebrae. And another type of surgery that can be done would be spinal fusion, in which the bone is transplanted into the back of the spine. The bone then heals and fuses with the spine, which then creates a strong bone mass and stabilizes the entire spine. Moving on to dextroscoliosis, which is another um, finding that the radiologist had. Now, for dextroscoliosis, um, the definition of dextroscoliosis is scoliosis of the spine with a curvature of the spine to the right. Now, some of the causes, and however, majority of the types of scoliosis are caused by idiopathic factors, meaning that the cause is unknown. However, some other causes may include trauma to the spinal column, degenerative spinal diseases, or neuromuscular diseases forcing the spine to curve to the right. And now some symptoms, which depend on the degree of curvature, we have mild, which would be the curving of the spine from 25 to 35 degrees, would only require a brace or body cast. And then we have severe, which would be the curve is greater than 40 degrees and would require surgery. And now some of the symptoms would be ribs on one side of the body protruding out more than the other, an uneven waistline, difficulty breathing if lung is compressed, and the lack of mobility. Now, with this patient had mild dextroscoliosis, so it really wasn't visible in the AP projection. However, I still found it interesting because I didn't know that there were other types of uh, scoliosis, and learning about this one just uh, got me more interested in the field and the field of the spine and how scoliosis comes to affect it. And now for the conclusion, making this case presentation and looking back at the actual procedure, I was able to gain experience and open new doors for myself when it comes to evaluating radiographs and the findings that can come with it. I never knew that there were so many things that one can see in a in a radiograph, and even though it looks normal, there can be so many things that can be abnormal. And even though a patient may seem normal and healthy, when viewing a radiograph and noticing any form of pathology has made me more aware and interested in what comes after taking an X-ray. And learning about anterior listhesis and dextroscoliosis and their appearance on a radiograph has pushed me for the future to be well prepared for the changes in regards to patient care or technical factors for these type of conditions, as well as other pathological abnormalities that I might come across. And this is my presentation, guys. I hope you guys enjoyed it. Thank you.